Chapter 38. Trauma. What widely accepted protocol does trauma care in the United States follow?
The A, Advanced, T, Trauma, L, Life, S, Support, ATLS, precepts of the American College of Surgeons.
What are the three main elements of the ATLS protocol?
1. Primary survey, resuscitation. 2. Secondary survey. 3. Definitive care.
How and when should the patient history be obtained?
It should be obtained while completing the primary survey. Often the rescue squad, witnesses, and family members must be relied upon.
Primary survey. What are the 5 steps of the primary survey?
Think ABCDEs. A. Airway and C-spine stabilization. B. Breathing. C. Circulation. D. Disability. E. Exposure and environment.
What principles are followed in completing the primary survey?
Life-threatening problems discovered during the primary survey are always addressed before proceeding to the next step.
Airway. What are the goals during assessment of the airway?
Securing the airway and protecting the spinal cord.
In addition to the airway, what must be considered during the airway step?
Spinal immobilization.
What comprises spinal immobilization?
Use of a full backboard and rigid cervical collar.
In an alert patient, what is the quickest test for an adequate airway?
Ask a question. If the patient can speak, the airway is intact.
What is the first maneuver used to establish an airway?
Chin lift, jaw thrust, or both. If successful, often an oral or nasal airway can be used to temporarily maintain the airway.
If these methods are unsuccessful, what is the next maneuver used to establish an airway?
Endotracheal intubation, either nasal or oral. Oral if the patient is not breathing with inline C-spine traction.
When is nasotracheal intubation contraindicated?
In patients with maxillofacial fracture or apnea.
If all other methods are unsuccessful, what is the definitive airway?
Cricothyroidotomy, also known as surgical airway. Incise the cricothyroid membrane between the cricoid cartilage inferiorly and the thyroid cartilage superiorly and place an endotracheal or tracheostomy tube into the trachea.
What must always be kept in mind during difficult attempts at establishing an airway?
Spinal immobilization and adequate oxygenation. If at all possible, patients must be adequately ventilated with 100% oxygen using a bag and mask before any attempt at establishing an airway.
Breathing. What are the goals in assessing breathing?
Securing oxygenation and ventilation. Treating life-threatening thoracic injuries.
What comprises adequate assessment of breathing?
Inspection for air movement, respiratory rate, cyanosis, tracheal shift, jugular venous distension, asymmetric chest expansion, use of accessory muscles of respiration, open chest wounds. Auscultation for breath sounds. Percussion for hyperresonance or dullness over either lung field. Palpation for presence of subcutaneous emphysema, flail segments.
What are the life-threatening conditions that must be diagnosed and treated during the breathing step?
Tension pneumothorax, open pneumothorax, massive hemothorax.
Pneumothorax. What is it?
Injury to the lung, resulting in release of air into the pleural space between the normally opposed parietal and visceral pleura.
How is it diagnosed?
Tension pneumothorax is a clinical diagnosis. Dyspnea, jugular venous distension, tachypnea, anxiety, pleuritic chest pain, unilateral decreased or absent breath sounds, tracheal shift away from the affected side, hyperresonance on the affected side.
What is the treatment of a tension pneumothorax?
Immediate decompression by needle thoracostomy in the second intercostal space mid-clavicular line, followed by tube thoracostomy placed in the anterior mid-axillary line in the fourth intercostal space, level of the nipple in men.
What is the medical term for a sucking chest wound?
Open pneumothorax.
How is an open pneumothorax diagnosed and treated?
Diagnosis usually obvious, with air movement through a chest wall defect and pneumothorax on chest X-ray. Treatment in the ED, with or without intubation with positive pressure ventilation, tube thoracostomy, chest tube, occlusive dressing over chest wall defect.
What does a pneumothorax look like on chest X-ray?
Loss of lung markings.
Flail chest. What is it?
2 separate fractures in 3 or more consecutive ribs.
How is it diagnosed?
A flail segment of chest wall that moves paradoxically, sucks in with inspiration and pushes out with expiration opposite the rest of the chest wall.
What is the major cause of respiratory compromise with flail chest?
Underlying pulmonary contusion.
What is the treatment?
Intubation with positive pressure ventilation and PEEP as needed. Let ribs heal on their own.
Cardiac tamponade. What is it?
Bleeding into the pericardial sac, resulting in constriction of the heart, decreasing inflow, and resulting in decreased cardiac output. The pericardium does not stretch.
What are the signs and symptoms?
Tachycardia or shock with Beck's triad, pulsus paradoxus, Kussmaul sign.
Define the following. Beck's triad.
1. Hypotension. 2. Muffled heart sounds. 3. JVD.
Kussmaul sign.
JVD with inspiration.
How is cardiac tamponade definitively diagnosed?
Ultrasound. Echocardiogram.
What is the treatment?
Immediate IV fluid bolus with pericardiocentesis. Subsequent surgical exploration is mandatory. Pericardiocentesis is a temporizing option, rare.
Massive hemothorax. How is it diagnosed?
Hypotension, unilaterally decreased or absent breath sounds, dullness to percussion, chest X-ray, CT scan, chest tube output.
What is the treatment?
Volume replacement. Tube thoracostomy, chest tube. Use of cell saver if available. Removal of the blood, which will allow apposition of the parietal and visceral pleura, sealing the defect and slowing the bleeding.
What are indications for emergent thoracotomy for hemothorax?
Massive hemothorax equals 1. 1,500 milliliters of blood on initial placement of chest tube. 2. Persistent greater than 200 milliliters of bleeding via chest tube per hour times 4 hours.
Circulation. What are the goals in assessing circulation?
Securing adequate tissue perfusion, treatment of external bleeding.
What is the initial test for adequate circulation?
Palpation of pulses. As a rough guide, if a radial pulse is palpable, then systolic pressure is at least 80 millimeters mercury. If a femoral or carotid pulse is palpable, then systolic pressure is at least 60 millimeters mercury.
What comprises adequate assessment of circulation?
Heart rate, blood pressure, peripheral perfusion, urinary output, mental status, capillary refill, normal less than 2 seconds, exam of skin, cold, clammy equals hypovolemia.
Who can be hypovolemic with normal blood pressure?
The young. Autonomic tone can maintain blood pressure until cardiovascular collapse is imminent.
Which patients may not mount a tachycardic response to hypovolemic shock?
Those with concomitant spinal cord injuries, those on beta blockers, well-conditioned athletes.
How are sites of external bleeding treated?
By direct pressure, with or without tourniquets.
What is the best and preferred IV access in the trauma patient?
2 large-bore IVs, 14 to 16 gauge, IV catheters in the upper extremities, peripheral IV access.
What are alternate sites of IV access?
Percutaneous and cut-down catheters in the lower leg saphenous, central access into femoral, jugular, subclavian veins.
For a femoral vein catheter, how can the anatomy of the right groin be remembered?
Lateral to medial navel, N nerve, A artery, V vein, E extralymphatic material, L lymphatics. Navel. Thus, the vein is medial to the femoral artery pulse, or think venous close to penis.
What is the trauma resuscitation fluid of choice?
Lactated ringers, LR solution. Isotonic, and the lactate helps buffer the hypovolemia-induced metabolic acidosis.
What types of decompression do trauma patients receive?
Gastric decompression with an NG tube and Foley catheter bladder decompression after normal rectal exam.
What are the contraindications to placement of a Foley?
Signs of urethral injury, severe pelvic fracture in men, blood at the urethral meatus, penile opening, high writing ballotable prostate, loss of urethral tethering, scrotal perineal injury ecchymosis.
What tests should be obtained prior to placing a Foley catheter if urethral injury is feared?
A retrograde urethrogram, RUG, dye in penis retrograde to the bladder, and X-ray looking for extravasation of dye.
How is gastric decompression achieved with a maxillofacial fracture?
Not with an NG tube, because the tube may perforate through the cribriform plate into the brain. Place an oral gastric tube, OGT, not an NG tube.
Disability. What are the goals in assessing disability?
Determination of neurologic injury. Think neurologic disability.
What comprises adequate assessment of disability?
Mental status, Glasgow Coma Scale, GCS. Pupils, a blown pupil suggests ipsilateral brain mass, blood, as herniation of the brain compresses CN3. Motor sensory, screening exam for lateralizing extremity movement, sensory deficits.
Describe the GCS scoring system.
Eye-opening E. 4. Opens spontaneously. 3. Opens to voice, command. 2. Opens to painful stimulus. 1. Does not open eyes. Think eyes equals 4 eyes. Motor response, M. 6. Obeys commands. 5. Localizes painful stimulus. 4. Withdraws from pain. 3. Decorticate posture. 2. Decerebrate posture. 1. No movement. Think motor equals 6-cylinder motor. Verbal response, V. 5. Appropriate and oriented. 4. Confused. 3. Inappropriate words. 2. Incomprehensible sounds. 1. No sounds. Think verbal equals Jackson 5.
What is the GCS score for a dead man?
GCS 3.
What is the GCS score for a patient in a coma?
GCS less than or equal to 8.
How does scoring differ if the patient is intubated?
The verbal evaluation is omitted and replaced with a T. Thus, the highest score for an intubated patient is 11T.
Exposure and environment. What are the goals in obtaining adequate exposure?
Complete disrobing to allow a thorough visual inspection and digital palpation of the patient during the secondary survey.
What is the environment of the E?
Keep a warm E, environment. In other words, keep the patient warm. A hypothermic patient can become coagulopathic.
Secondary survey. What principle is followed in completing the secondary survey?
Complete physical exam, including all orifices, ears, nose, mouth, vagina, rectum.
Why look in the ears?
Hemotympanum is a sign of basilar skull fracture. Otorrhea is a sign of basilar skull fracture.
Examination of what part of the trauma patient's body is often forgotten.
The patient's back. Log roll the patient and examine.
What are typical signs of basilar skull fracture?
Raccoon eyes, battle sign, clear otorrhea or rhinorrhea, hemotympanum.
What diagnosis in the anterior chamber must not be missed on the eye exam?
Traumatic hyphema equals blood in the anterior chamber of the eye.
What potentially destructive lesion must not be missed on the nasal exam?
Nasal septal hematoma. The hematoma must be evacuated. If not, it can result in pressure necrosis of the septum.
What is the best indication of a mandibular fracture?
Dental malocclusion. Tell the patient to bite down and ask, "Does that feel normal to you?"
What signs of thoracic trauma are often found on the neck exam?
Crepitus or subcutaneous emphysema from tracheobronchial disruption or pneumothorax, tracheal deviation from tension pneumothorax, jugular venous distension from cardiac tamponade, carotid bruit heard with seatbelt neck injury resulting in carotid artery injury.
What is the best physical exam for broken ribs or sternum?
Lateral and anterior posterior compression of the thorax to elicit pain, instability.
What physical signs are diagnostic for thoracic great vessel injury?
None. Diagnosis of great vessel injury requires a high index of suspicion based on the mechanism of injury, associated injuries, and chest X-ray radiographic findings, for example, widened mediastinum.
What must be considered in every penetrating injury of the thorax at or below the level of the nipple?
Concomitant injury to the abdomen. Remember, the diaphragm extends to the level of the nipples in the male on full expiration.
What is the significance of subcutaneous air?
Indicates pneumothorax until proven otherwise.
What is the proper technique for examining the thoracic and lumbar spine?
Log rolling the patient to allow complete visualization of the back and palpation of the spine to elicit pain over fractures, step-off, spine deformity.
What conditions must exist to pronounce an abdominal physical exam negative?
An alert patient without any evidence of head or spinal cord injury or drug or ETOH intoxication. Even then, the abdominal exam is not 100% accurate.
What physical signs may indicate intra-abdominal injury?
Tenderness, guarding, peritoneal signs, progressive distension. Always use a gastric tube for decompression of air. Seatbelt sign.
What is the seatbelt sign?
Ecchymosis on lower abdomen from wearing a seatbelt. Approximately 10% of patients with this sign have a small bowel perforation.
What must be documented from the rectal exam?
Sphincter tone, as an indication of spinal cord injury. Presence of blood, as an indication of colon or rectal injury. Prostate position, as an indication of urethral injury.
What is the best physical exam technique to test for pelvic fractures?
Lateral compression of the iliac crests and greater trochanters, and anterior-posterior compression of the symphysis pubis to elicit pain, instability.
What is the halo sign?
Cerebrospinal fluid from nose or ear will form a clear halo around the blood on a cloth.
What physical signs indicate possible urethral injury, thus contraindicating placement of a Foley catheter?
High riding, ballatable prostate on rectal exam, presence of blood at the meatus, scrotal or perineal ecchymosis.
What must be documented from the extremity exam?
Any fractures or joint injuries, any open wounds, motor and sensory exam, particularly distal to any fractures, distal pulses, peripheral perfusion.
What complication after prolonged ischemia to the lower extremity must be treated immediately?
Compartment syndrome.
What is the treatment for this condition?
Fasciotomy, forecompartment below the knee.
What injuries must be suspected in a trauma patient with a progressive decline in mental status?
Epidural hematoma, subdural hematoma, brain swelling with rising intracranial pressure. But hypoxia-hypotension must be ruled out.
Trauma studies. What are the classic blunt trauma ED X-rays?
1. AP, anterior to posterior chest film. 2. AP pelvis film.
What are the common trauma labs?
Blood for complete blood count, chemistries, amylase, liver function tests, lactic acid coagulation studies, and type and cross-match. Urine for urinalysis.
Will the hematocrit be low after an acute massive hemorrhage?
No time to equilibrate.
How can a C-spine be evaluated?
1. Clinically by physical exam. 2. Radiographically.
What patients can have their C-spines cleared by physical examination?
No neck pain on palpation with full range of motion, from. With no neurologic injury, GCS 15. No ETOH drugs, no distracting injury, no pain meds.
How do you rule out C-spine bony fracture?
CT scan of the C-spine.
What do you do if there is no bony C-spine fracture on CT scan and you cannot get an MRI in a comatose patient?
This is controversial. The easiest answer is to leave the patient in a cervical collar.
Which X-rays are used for evaluation of cervical spine ligamentous injury?
MRI lateral flexion and extension C-spine films.
What findings on chest film are suggestive of thoracic aortic injury?
Widened mediastinum, most common finding, apical pleural capping, loss of aortic contour, knob, AP window, depression of left mainstem bronchus, nasogastric tube tracheal deviation, pleural fluid, elevation of right mainstem bronchus. Clinical suspicion, high-speed mechanism.
What study is used to rule out thoracic aortic injury?
Spiral CT of mediastinum looking for mediastinal hematoma with CTA thoracic arch aortogram. Gold standard.
What percentage of thoracic aortograms will reveal an aortic injury?
Only about 10% of studies are positive.
What is the most common site of thoracic aortic traumatic tear?
Just distal to the takeoff of the left subclavian artery.
What studies are available to evaluate for intra-abdominal injury?
FAST, CT, DPL.
What is a FAST exam?
Ultrasound. F, focused, A, assessment, with S, sonography, for T, trauma, equals FAST.
What does the FAST exam look for?
Blood in the peritoneal cavity looking at Morrison's pouch, bladder, spleen, and pericardial sac.
What does DPL stand for?
D, diagnostic, P, peritoneal, L, lavage, DPL.
What diagnostic test is the test of choice for evaluation of the unstable patient with blunt abdominal trauma?
FAST.
What is the indication for abdominal CT in blunt trauma?
Normal vital signs with abdominal pain, tenderness.
What is the indication for DPL or FAST in blunt trauma?
Unstable vital signs, hypotension.
How is a DPL performed?
Place a catheter below the umbilicus in patients without a pelvic fracture into the peritoneal cavity. Aspirate for blood, and if less than 10 milliliters are aspirated, infuse 1 liter of saline or lactated ringers. Drain the fluid by gravity and analyze.
What is a grossly positive DPL?
Greater than or equal to 10 milliliters blood aspirated.
Where should the DPL catheter be placed in a patient with a pelvic fracture?
Above the umbilicus. A common error. If you go below the umbilicus, you may get into a pelvic hematoma tracking between the fascial layers and thus obtain a false positive DPL.
What constitutes a positive peritoneal tap?
Prior to starting a peritoneal lavage, the DPL catheter should be aspirated. If more than 10 milliliters of blood or enteric contents are aspirated, then this constitutes a positive tap and requires laparotomy.
What are the indicators of a positive peritoneal lavage in blunt trauma?
Classic: inability to read newsprint through lavaged fluid. RBC greater than or equal to 100,000 millimeters cubed. WBC greater than or equal to 500 millimeters cubed. Note, millimeters cubed, not millimeters squared. Lavage fluid, lactated ringers or normal saline, drained from chest tube, Foley, and G-tube. Less common: bile present, bacteria present, feces present, vegetable matter present, elevated amylase level.
What must be in place before a DPL is performed?
NG tube and Foley catheter to remove the stomach and bladder from the firing line.
What injuries does CT miss?
Small bowel injuries and diaphragm injuries.
What injuries does DPL miss?
Retroperitoneal injuries.
What study is used to evaluate the urethra in cases of possible disruption due to blunt trauma?
Retrograde urethrogram, RUG.
What are the most emergent orthopedic injuries?
1. Hip dislocation, must be reduced immediately. 2. Exsanguinating pelvic fracture, binder or external fixator.
What findings would require a coleotomy in a blunt trauma victim?
Peritoneal signs, free air on chest X-ray or CT, unstable patient with positive FAST exam or positive DPL results.
What is the treatment of a gunshot wound to the belly?
Exploratory laparotomy.
What is the evaluation of a stab wound to the belly?
If there are peritoneal signs, heavy bleeding, shock, unstable vital signs, perform exploratory laparotomy. Otherwise, many surgeons either observe the asymptomatic stab wound patient closely, use local wound exploration to rule out fascial penetration, or use DPL.
Penetrating neck injuries. What depth of neck injury must be further evaluated?
Penetrating injury through the platysma.
Define the anatomy of the neck by trauma zones. Zone 3.
Angle of the mandible and up.
Zone 2.
Angle of the mandible to the cricoid cartilage.
Zone 1.
Below the cricoid cartilage. Note: the zones are in the same anatomic order as the Lefort facial fractures, 3-2-1. Or 1-2-3 following carotid blood flow.
How do most surgeons treat penetrating neck injuries? Those that penetrate the platysma by neck zone. Zone 3.
Selective exploration.
Zone 2.
Surgical exploration versus selective exploration.
Zone 1.
Selective exploration.
What is selective exploration?
Selective exploration is based on diagnostic studies that include agram or CT agram, bronchoscopy, esophagoscopy.
What are the indications for surgical exploration in all penetrating neck wounds? Zones 1, 2, and 3.
Hard signs of significant neck damage: shock, exsanguinating hemorrhage, expanding hematoma, pulsatile hematoma, neurologic injury, sub-Q emphysema.
Miscellaneous trauma facts. What is the 3-for-1 rule?
The trauma patient in hypovolemic shock acutely requires 3 liters of crystalloid lactated ringers for every 1 liter of blood loss.
What is the minimal urine output for an adult trauma patient?
50 milliliters per hour.
How much blood can be lost into the thigh with a closed femur fracture?
up to 1.5 liters of blood.
Can an adult lose enough blood in the closed skull from a brain injury to cause hypovolemic shock?
Absolutely not, but infants can lose enough blood from a brain injury to cause shock.
Can a patient be hypotensive after an isolated head injury?
Yes, but rule out hemorrhagic shock.
What is the brief ATLS history?
An ample history. A. Allergies. M. Medications. P. PMH. L. Last meal, when. E. Events of injury, etc. AMPLE. Ample.
In what population is a surgical cricothyroidotomy not recommended?
Any patient younger than 12 years. Instead, perform needle cricothyroidotomy.
What are the signs of a laryngeal fracture?
Subcutaneous emphysema in neck. Altered voice. Palpable laryngeal fracture.
What is the treatment of rectal penetrating injury?
Diverting proximal colostomy. Closure of perforation, if easy, and definitely if intraperitoneal, and presacral drainage.
What is the treatment of extraperitoneal minor bladder rupture?
Bladder catheter, Foley drainage and observation. Intraperitoneal or large bladder rupture requires operative closure.
What intra-abdominal injury is associated with seatbelt use?
Small bowel injuries, L2 fracture, pancreatic injury.
What is the treatment of a pelvic fracture?
With or without pelvic binder until the external fixator is placed, IVF, blood, with or without agram to embolize bleeding pelvic vessels.
Bleeding from pelvic fractures is most commonly caused by arterial or venous bleeding.
Venous, approximately 90%.
If a patient has a laceration through an eyebrow, should you shave the eyebrow prior to suturing it closed?
No, 20% of the time the eyebrow will not grow back if shaved.
What is the treatment of extensive irreparable biliary, duodenal, and pancreatic head injury?
Trauma Whipple.
What is the most common intra-abdominal organ injured with penetrating trauma?
Small bowel.
How high up do the diaphragms go?
To the nipples, intercostal space number 4. Thus, intra-abdominal injury with penetrating injury below the nipples must be ruled out.